Hi, I'm Afroza Sharmin. I'm a general surgery registrar in the Thames Valley Deanery and a clinical research fellow in my first year of PhD with the Department of Surgery and Cancer at Imperial College London. I'm glad to share the outcome of our scoping review, exploring effective strategies in promoting diversity, equity, and inclusivity in surgery. This was presented at the Association of Surgeons of Great Britain and Ireland International Conference 2025, and we won the third prize in the BJS Prize session. DEI is quite the buzzword, but what is DEI? Diversity encompasses gender, gender identity, race, and all the way to sexual orientation and religious affiliation. While this review addresses diversity comprehensively, the literature search did not yield results beyond gender, race, and ethnicity. Equity is the fair treatment based on individual needs. Inclusivity refers to a sense of belonging by embracing diverse perspectives. And why is DEI important in surgery? Literature has showed it improves patient outcomes, patient-physician concordance due to commonality in cultural competence. This leads to better communication. Diverse teams also drive innovation and reduce disparities. But despite these well-documented literature, support from policy like the Equality Act 2010 and social media initiatives that show visibility, DEI progress in surgery remains slow. Only 17% of UK consultants are women, 25% from ethnic minorities, and these numbers are even dire in surgical academia. The barriers identified include leaky pipeline. This is a phenomenon where there is a gradual loss of representation from medical school to residency and beyond. The well-known Baroness Kennedy Review from 2020, which was commissioned by the Royal College of Surgeons of England, exposed unconscious bias, institutional racism, and sexism, among other causes. Therefore, the rationale of this review is that while we've long recognized the value of diversity, the evidence of what actually works remains fragmented. There is a shift towards impact assessment of interventions rather than just stating what works or what might not work. Contextualizing this will help surgical training programs and educators with evidence-based, actionable strategies. Our objectives were to identify common themes, uncover barriers to implementation, analyze the short and long-term outcomes across different career stages, and really to provide recommendations to stakeholders and future researchers. We followed the PRISMA guidelines for scoping reviews. We analyzed different databases, including PubMed, Embase, and Cochrane Library, with predefined search strategies between June 2023 and November 2024. Bias assessment were conducted using the adapted 2018 Critical Appraisal Skills Program checklist, and followed by that, we used thematic synthesis to identify patterns across different strategies. These were our inclusion criteria. We kept it broad, involving all surgical specialties, medical students, doctors in training, surgical consultants, attendings, and we use terminologies relevant to different global contexts. More importantly, peer-reviewed articles focusing on well-formulated strategies to achieve DEI with measurable outcomes were strictly followed. Our initial search showed 823 hits, and we included 18 studies after applying the inclusion criteria. There were 4 main themes that were identified, although some studies used multi-method strategies. These included pipeline programs, early phase recruitment strategies, mentorship opportunities, and comprehensive institutional change. Within pipeline programs, delivering workshops, lectures, providing scholarships, and arranging clerkships were included. These were primarily to address negative perceptions and provide early exposure to surgical careers. Within the early phase recruitment category, there was a shift from moving beyond rigid academic cutoffs to a more holistic approach where there was a balance between academic achievements and personal attributes and experiences. Mentorship was provided from medical school to residency and early career stages. Comprehensive institutional changes included creation of diversity committees and conducting faculty training, all to foster inclusive environments and mitigate biases. The overall results were positive across all the 4 categories, mainly impacting the short-term recruitments. Strategies such as the mentorship-driven approaches and holistic approach were cost-effective, while others improved recruitment and long-term career growth. There are some critical observations that we'd like to highlight, which impacts the interpretation of the results. These are heterogeneity of multifaceted strategies. 11 out of the 18 studies involved multimodal programs. While these were effective, it was difficult to identify what the impact of individual elements were. One key insight was the distinction between mentorship and sponsorship. Mentors being a guide that seemed to be important at the early stages of your career, while sponsors are ones who actively advocate for individuals and open opportunities. And this seems to be more important during the later stages of your career, where leadership progressions become important. 61% of the studies involved mentorship, while sponsorship was barely included in these reviews. We were cautious against interpreting some of the results, as most of the studies assumed causality, where confounders were not adjusted. And many of the studies did not involve any control groups, which was understandable as most of the studies were done for minority cohorts. 39% of the studies included longitudinal studies where they assessed residency attrition, faculty hires, and leadership roles. Here, mentorship showed the best return on investment. In terms of role of representation in DEI, there has been 2 ends of a spectrum. At one end, there was the attraction, selection, attrition paradigm, where representation attracted applicants and improved retention if there was a diverse faculty in visible roles. While on the other end of the spectrum, it does come with minority tax, where DEI work burdens minorities disproportionately. Interestingly, most of the studies coming out of this review came from the US. Now, why is that? It's difficult to explain and barely speculatory. It could be due to contrasting incentives, funding availability, historical, and perhaps political issues to be the likely drivers. In conclusion, DEI research in surgery is moving from merely describing theoretical frameworks to evidence-based DEI interventions. These findings hopefully provide actionable strategies for surgical programs seeking to enhance DEI at all stages. However, the challenge remains to maintain sustainable implementation and broader applicability across healthcare systems. Thank you for listening.